I request Dr. Shareyu Wankhede ma'am to say a few words.
Hello. I just wanted to thank Sushrutee committee members for giving me this opportunity. And I would like to add one thing that always we are thinking of oocyte and sperm only. And we are neglecting a uterine and endometrium part. As Dr. Norman told us to evaluate the uterus well before transferring the embryo. Now, he has also shown us one cases that they are treating from 2016 to 2019 only one case, and they have wasted 7 to 8 embryos in false passage. If you have looked the video then before, it's a very good presentation that there is a false passage, and because of that they have wasted 7 to 8 good quality embryos. So before transferring the embryos, always evaluate the uterine cavity well and see the endometrium also, and false passage. Keep an eye on false passage. And embryos, all of course, you have to see the embryo quality, and blastocyst transfer is very important. And if you have many blastocysts, then choose only single embryo transfer to avoid multiple pregnancies. That is a key message, because multiple pregnancy leads to with complications during pregnancy like PIH and GDM. And one more thing, that being a BMS is absolute not the limitations to achieve our goals. To students, please work well, do hard practice, and your skills will reach you your destination. And no other limits there to stop you from your progress. So good luck and thank you again. Thank you.
Thank you so much, ma'am. Now I would request Anuja ma'am to felicitate the coordinators of this session, Dr. Neha Rathod and Dr. Bhapkar ma'am. Now we conclude this session 3 and hand over the mic to Dr. Sapna Baviskar ma'am for the next session.
Hello. Good afternoon, all. I, Dr. Sapna Baviskar, coordinator for today's session, welcome you all. Moving forward to chair this session, I would request to Dr. Respected Girija Senikop ma'am, Professor and HOD at KLE Ayurveda College, Belvati, Karnataka, and Dr. Sujit Shinde sir, Director of Matru Charya Nursing Home and Matru Ayurved, Pune, to take their seats on dais. Now, I would request to our eminent speaker, Dr. Bhushan Bhalgat sir, to take their seat on dais. Please welcome, sir. I request Dr. Umesh Lunawat sir to welcome our esteemed chairperson with rose for warm welcome. Please, sir. तुम्हीच करा. Now I request sir to welcome our chairpersons. We are so blessed as Dr. Bhushan sir is our guest speaker. Though he is practicing as in modern medicine, but his roots are come from Ayurveda, as he is son of Dr. Madhuri Bhalgat ma'am, who is professor and HOD at SVNH Ayurved College, Rahuri. And also his all childhood is well nurtured by our Dr. Suhas Herlekar's mother, and he is known with Herlekar family. Doctor, it is my great pleasure to introduce Dr. Bhushan sir. Dr. Bhushan Bhalgat sir is currently associated with Sahyadri Group of Hospitals, Pune, as a consultant oncosurgeon, and sir is also visiting consultant as at Nagar. He had gained a profound amount of hands-on experience on operating cancer patients over the practice of 7 years. He graduated as a MBBS from highly renowned KM Hospital, Mumbai, and post-graduated as a MS from MS Government Medical College and Ghati Hospital, Aurangabad. Thereafter, he attained the highest degree of surgery as a MCH at the prestigious SMS Government Medical College, Jaipur. Furthermore, he had attained higher laparoscopic training at World Laparoscopy Hospital, Delhi. And now sir is performing more and more oncosurgeries in field of gynec, gastrointestinal cancers, skin cancers, and many more. Now I would request to sir to continue his lecture.
Thank you, madam, for such a great introduction. Myself, Dr. Bhushan Bhalgat, basically belonging to Ahmednagar, son of Dr. Madhuri Bhalgat, a gynecologist at Vivekanand Nursing Home, Rahuri, and basically practicing in East Pune as an oncosurgeon. I know it's lunchtime. Everybody is very, very hungry. The food is delicious. I would not take much time. The lecture will be very short and crisp. I would be basically talking on infertility. First of all, let me ask you a question. What is more common in today's era? Is it infertility which is more common, or is it cancer which is more common? Both. So among the benign conditions which gynecologists commonly see, infertility is booming like anything. And as an oncologist, we see gynec cancers and especially breast cancers which is booming in females very commonly. So is there any link in between these two? Are there any common factors which is causing both? Yes, obesity, smoking, hormonal imbalances, genetics, all these factors are common to both infertility and cancers. Also, I would also talk on the topic whether cancer causes infertility or whether infertility can cause cancer. So one by one, let us go through these topics. How do gynec cancers cause infertility? Do they cause infertility? Do non-gynec cancers also cause infertility, like thyroid cancers, lymphomas, leukemias? Does infertility cause cancer? Very important question is, does infertility treatment cause cancer? This is a big myth among many people that infertility treatment causes cancer. And I would also talk on fertility preservation options. We are more, as an oncologist, we deal with fertility preservation options outside the uterus. You people, as an infertility specialist, you are more well versed with ovulation. We are well versed with IVF. You are well versed with intrauterine adhesion removals. We as oncologists, we try to preserve the organs while performing oncosurgeries. So I would like to talk on that topic in the fifth topic. Apart from that, the hot topic of today, which is not related to infertility, I would also stress upon about cancer screening in females, that is breast cancers, cervix cancers, the cervix vaccines which are available. We all are aware about everything, but we do not do. I would like to take a poll among the audience. How many of you have taken the cervix cancer vaccine? Only a handful, only a handful. I can count this, it is less than 10. We all are doctors, we are all are aware of everything, but we do not. So I would like to stress upon that topic also. And in the last, I would like to show you some interesting cases which I perform as an oncologist. So coming to gynec cancers and infertility. Do gynec cancers and their treatment cause infertility? The 4 cancers I would like to specify. Breast cancer is also one of the gynec cancer. I assume maximum breast cancer patients do not come to us as a surgeons. They come to gynecologists because people are more comfortable with gynecologists regarding breast cancers or breast lumps also. So I would like to stress upon that also. So regarding cervix cancer, what is the direct cause of infertility is usually the obstruction which is caused by the cervical growth. So is there any way we can stop that? No. In India, the female who comes to us as a cervix cancer presents with a PV bleeding, not as a early, if you want to diagnose a cervix cancer in early stages, the symptom has to be post-coital bleeding. That is the first early symptom of cervix cancer, but in India it is not considered important. Only when the patient has heavy bleeding or unnatural PV bleeding, the patient presents when the growth is very large. That time, the cervical canal is totally obstructed and patient cannot be fertile. Obviously, that is the second important thing in the life of the patient at that moment. But yes, obstruction of cervix is the cause of infertility directly. Secondly, because patients come in that stage where hysterectomy or radiation is the only treatment available. Trachelectomy, I hope you have heard of the term I have written in the 4th line, is trachelectomy. Trachelectomy means removing only the cervix and the upper part of vagina and suturing the uterus to the vagina, lower part of uterus to the vagina. So why this is important? If you ask me how many trachelectomy I have done, I have only seen true trachelectomies in my life. I do not get patients who are fit enough to do a trachelectomy, that is removal only of the cervix. So hysterectomy remains the only option, radical hysterectomy, or radiation remains the only option. And both these cause infertility. So in Indian settings, this is the setting of the patients we get, and that the treatment itself causes infertility in cervix cancer. There is new thinking for infertility because cervix cancer patients are not always old patients. They are in the middle age group, like 35 to 45, and some of them still want fertility. So in those cases where we want fertility in cervix cancer patients, there is a research going on for neoadjuvant chemotherapy. What is it? Neoadjuvant means giving chemotherapy before going for surgery. So that is going to reduce the size of tumor, and later on we can plan trachelectomies for those patients. So that is in the research phase to preserve fertility for such patients. Coming to the second cancer, that is uterine cancer. Unfortunately for uterine cancers, only 2 options are there. When the fertility is complete, TAH and BSO is the treatment of choice for uterine cancers. Laparoscopy is the preferred method for endometrial or uterine cancers. But few females come in a stage like they are 20 years old, 25 years old, and they want fertility. So what is the option is progestins. Megestrol acetate or levonorgestrel IUD is the treatment of choice for patients who want fertility preserving options. So how do we do that? We give the progestins for the patient. Every 6 monthly the patient comes back to us. We keep doing DNC. If we find that the tumor is absent after 6 months of progestin treatment and the patient wants fertility, we allow to get her pregnant. If she doesn't want fertility still, if she's thinking, no, I want to continue on progestin, I don't want hysterectomy also, but I don't want to get fertile right now also. So she is kept on progestin. Every 6 months DNC is done. Unless and until we find a tumor. The day we find a tumor on DNC, we advise a hysterectomy on progestin. So that is the way we go ahead for a fertility preserving options in uterine cancers. Unfortunately for ovarian cancer, I would like to share a case of ovarian cancer which recently I saw in my OPD. The female was 25-year-old, well-educated architect. So we can believe that she was very well educated. She thought that she was getting fat. She got a small belly. She thought she was getting fat. She didn't do a sonography. Obviously, why would anybody get a sonography for being fat? She joined a gym. After joining gym for a few months, she realized that she is not getting slim. Still, it was not in her mind to get a sonography until she had some pain in the abdomen. So pain was the symptom which made her do a sonography. Unfortunately, after doing a sonography, there was a large ovarian mass about a size of 7 to 8 kgs. And after removal, because she was a unmarried female, we wanted to preserve the fertility. We removed only that side ovary and we did a ovarian surgical staging. That what is the surgical staging? Is removing only one side of the ovary, removing the omentum, assessing the nodes, doing a peritoneal wash using normal saline. So that we did, and even after doing that, we did a later on when we evaluated after 6 months, we found another tumor in the other ovary. Now tell me what can we do? There is no option other than removing the other ovary also, and she had to opt for other fertility options. So such cases come to us in that. Unfortunately, in ovarian cancers, we don't have much option because ovarian cancer is a peritoneal disease. It disseminates in the peritoneum very easily. So the other factor which affects ovarian cancer in our patients is adhesions. When a patient of ovarian cancer comes with lot of peritoneal nodules, adhesions happen. Even after surgery, the raw surface, that is the peritoneum, after excising the peritoneum, there is a lot of raw surface which goes and sticks to the bowel. There is a chance that adhesions could be a cause of infertility in ovarian cancer management. Coming to breast cancer. Breast cancer is the most common female cancer, is the most common female gynec cancer also, and overall also it is the most common female cancer today in India and the world. We have very strong data regarding infertility and breast cancer. But because breast is not directly related to uterus or ovaries directly, the treatment which is used for breast cancer causes infertility. The breast cancer directly does not. And infertility is not the main problem in breast cancer treatment. It is amenorrhea. I would like to emphasize that the patients who take chemotherapy for breast cancer have amenorrhea for 12 months or more. That is chemotherapy related. But not all amenorrheic female taking treatment for breast cancer are infertile or subfertile. Many of them are still fertile. So amenorrhea is not a direct relation to fertility. Other way around, people who are infertile still can have periods. So in breast cancer, we cannot directly correlate fertility with amenorrhea, which is actually happening in the patients who are taking chemo. So that is a challenge for us. Cyclophosphamide is a drug which is commonly and not commonly, it is the drug which is present in the protocol for breast cancer treatment, and it causes amenorrhea. There is a research going on for GnRH agonist which suppress ovarian function temporarily. So what happens is we can use those agonists, suppress the function temporarily while the chemo is going on. Once chemo stops, we can bring back the ovarian function and we can bring back the fertility of the breast cancer patient. Now coming to non-gynec cancers. Do non-gynec cancers cause infertility? Not directly. It is the treatment of non-gynec cancers which cause infertility. Talking about thyroid cancer, some of you might have heard that there is treatment called radioactive iodine. It's not radiation directly, but it is something which we make the patient to drink. There is a solution which contains radioactive elements. Once inside the body, the elements emit radioactivity, and that causes thyroid cancer to diminish. But does it directly cause infertility? No. Though radioactivity is present in the body, directly radioactive iodine does not cause infertility, because thyroid cancers is a cancer of young population. Many patients come in between 25 to 40. Radioactive iodine is almost have to be given to every patient because some or the other residual tissue is found in the body other than thyroid even after total surgery. So RAI has to be given. It does not cause infertility. Other than that, leukemias and lymphomas. There are many chemotherapy which are strong. Blood cancer chemotherapy is much more harsher than the chemotherapy for solid organs, and yes, it causes infertility. Radiation. Radiation which is used for uterine cancers, which is used for non-gynec cancers, also causes infertility. There is no option other than using some shields while giving radiation. Other than that, cranial radiation. So there is radiation which is given for lymphoma, which is given to the pituitary gland, that causes hormonal imbalances and again infertility. So these are various ways in which infertility is caused to any cancer patients. Now coming to the second topic of today, does infertility cause cancer? Right now we were talking about whether cancer and cancer treatment causes infertility. Now let me talk about whether infertility directly causes cancer. Yes, like we already talked, endometrium cancer is caused due to estrogen hyperactivity in the body. Ovarian cancers, breast cancer, all are due to estrogen hyperactivity in the body. And yes, these hormonal imbalances also cause infertility in the body. So basically, hormonal imbalances is a connection between these cancers and infertility. Directly, infertility, can it cause cancer? No. But due to the hormonal imbalances which are present in both, that can cause infertility. Directly, not. Does treatment for infertility cause cancer? No, absolutely no. There was a myth that clomiphene citrate, due to the ovulation which is causing repeatedly, there is a repeated ovulation due to clomiphene, could it cause ovarian cancer? Yes, it was a myth previously. Now we are very sure, after the research which has been done through the years, there are multiple Danish studies which show that no infertility drug directly causes cancer. So it is totally safe regarding cancer to give infertility treatment. But yes, there is a small theoretical risk of borderline ovarian tumors, but they are very indolent and they can be managed safely. Now, what are the fertility preserving options we can use for cancer treatment? As you are more expert regarding this rather than us. Whenever we have a cancer patient and we want fertility, we straight away refer them to gynecologists who are specialized in IVF treatment. Yes, embryo preservation is the best among all. I assume I'm right. The second best option is oocyte preservation. Nowadays, in some patients on whom there is no ovulation, the girl is very young. Suppose there is a 6-year-old, 7-year-old girl who has some ovarian tumor or some other tumor where we want to give chemotherapy. In those patients, because ovulation induction is difficult, ovarian tissue preservation is an option. We do the oophorectomy. It's not done yet in India. The ovary is sent for cryopreservation. It can be reimplanted in the body later on. It's very research in the research process only, but it's an option. Also, radiation which can avoid the ovaries can be done. Higher forms of radiation like proton therapies, they are avoiding ovaries and we can avoid radiation to the ovaries. Modified surgery, like I already talked about, ovarian preserving surgeries, doing a unilateral oophorectomy, doing a trachelectomy, these all surgeries can prevent fertility by modifying the surgeries for such patients. Now this was all about infertility and cancer. I am more concerned and I am more specialized in not talking directly about infertility, because not all patients want fertility treatment when they come to cancer surgeons. But in general about cancers, I would like to talk about screening methods for other cancers, breast cancers, cervix cancers, and I would like to talk about vaccines also. So there is a WhatsApp knowledge going on everywhere that we have a vaccine for breast cancer. No, we do not have a vaccine for breast cancer. The only method by which we can detect breast cancer in an early stage is by screening. So what is screening in breast cancer is, every female, I would specify this, every female who has crossed 35 or 40, some studies say 40, we advise 35 to be safer. Every female who has crossed 35 must undergo a bilateral mammography every year once. I don't think many of us are following this, but we should follow this. And also females who have a family history, like if anybody has a very close relative, blood relative, not Sasubai, she has to be a mother, Maushi, Atya, Maushiची मुलगी, आजी, सासूबाई आणि त्यांच्या साईडचे नाही आहेत. So any blood relative who has a breast cancer, ovarian cancer or uterine cancer have to be more concerned and do a mammography maybe even 6 monthly. It's not in the guidelines, but we advise in a practical life that 6 monthly mammography is fine for those patients. But otherwise, please remember, I will again repeat, females who have crossed 35 or 40, do a mammography every yearly. It's a very simple test. Many of you might not have seen a mammography machine. It's a simple X-ray machine which has radiation which is lower than X-ray. It does not cause infertility. Some people think that radiation causes infertility. Multiple X-rays cause infertility. CT scans cause infertility. Yes, when used in much more amount than, like, if you do 12 CT scans in a year, that will cause infertility. Doing one mammography which has less radiation than even a simple X-ray will not cause infertility. So please get a mammo done. For if you are less than 35, for your moms, for your elder sisters. If you are yourself more than 35, do a mammography every yearly. Regarding cervix, most of you already know, you are all gynecologists. A pap smear or a HPV DNA test has to be done every 3 yearly or 5 yearly in every female who has crossed 21 or less than 65. But it's not possible in Indian setting for an unmarried female who has an intact hymen to go for a pap smear test. So we advise in practical life, once you are married, you start doing a pap smear test. That is the advice we give. At least until 65, you have to get it done every 3 yearly. HPV DNA along with pap, if done, it's best. If not, alone HPV DNA is best. If not, alone pap smear is best. It is a very cheap test. Almost 400 to 500 rupees is the running cost of the test. You can do it in your own OPD. You can advise your patients to get that done. One more thing I would like to talk about this test is, some people think if you are vaccinated for cervix cancer, you are not required to do a pap smear. Absolutely wrong. Even if you are vaccinated with cervix vaccine, you have to get a pap smear or HPV DNA in the same frequency, even though you are not vaccinated. You would ask me why. Cervix cancer prevents infection up to 98 to 99%. 1 or 2% definitely is not a big amount, but what if you are in that 1%? What if you are infected by 16 or 18 variant in that 1%? So to avoid that, 400 rupees every 3 yearly is not a big task. So you advise them, although you are vaccinated, you get your pap smear test done with your gynecologist or oncologist. Now talking about vaccines, most people know, but I would like to re-emphasize, there were 3 brands available until recently. Cervarix, which contains the variants 16 and 18, which are specific about cancer. There are multiple variants in cervix cancer. HPV is the cause. Like you have heard in COVID times, there is alpha, beta, gamma, delta, multiple numbers we have heard. In cervix, most important 16 and 18, that is present in all these 3. Cervarix contains only 16-18. Apart from that, Gardasil and Gardasil 9 contains other variants which are responsible for other infections regarding HPV, not cancers directly. Gardasil 9 contains 9 variants, that is 6, 11, 16, 18, 31, 33, 45, 52 and 58. So these variants are also okay. I would advise the middle one, that is Gardasil 4. But recently, our own Indian company, Serum Institute, has launched Cervavac. It is much cheaper. It is equally strong. It's not that it's because it's made in our own country, is it less potent? No, it is equally potent. It is all tested. You can use it. Its cost around, its MRP is 4,000, but if you ask outside, it is available for even 1,500 rupees. So you can ask the patient to use our own Indian brand, Cervavac. The dose which has to be given is 016. If the female is in between 9 to 12, 3 doses are not required. So whom to give is, the best period to give is between 9 to 12 years of age. If not given in that age, you can at least give before having your first sexual intercourse. In India, it is considered as marriage being the first time when we are exposed to a sexual intercourse. So we advise patients that at least before marriage you take that vaccine. Why 9 to 12? Why not before marriage for every patient? Because it takes almost 8 to 10 years for the immunity to develop at that location. Hence, it has to be taken at 9 to 12 years, because when the girl comes to a age when she is going to have her first sexual relation, at that time she has the immunity to fight HPV. Because that is why 9 to 12 is the best age. Now, whether can this vaccine be given in males also? Yes, in Australia, Australian guidelines give it for to children who are in between 9 to 12, who are boys. So for penile cancers also, it is in research, and very soon boys will also have to take this vaccine, because HPV is the cause of penile cancers and also oropharyngeal cancers. There is a very strong data. Oral cancers are caused by smoking or tobacco. Everybody knows that. Oropharynx cancer, the part behind the palate, the pharynx, जिथं आपण gargles करतो, that is called pharynx, that is the oropharynx. That cancer is caused by HPV. So to prevent that, very soon HPV vaccine will be given to males also. So this is the Cervavac vaccine which I was talking about. It has 4 components, 6, 11, 16, 18, which is present in Gardasil 4 also. It is available in 2. I'm not a proponent of Cervavac. I'm not coming from Serum Institute, or nobody is paying me for that. But because it is in the news, and we must know about it, because our patient asks us and we must be aware. So it is there. There are single dose vaccine vials, or there is double dose vials. So if you have 2 patients at a time, you can use double dose. If not, you can ask the patient to fetch a single dose vial and use that vaccine. That was about infertility previously. In between, the talk was about my favorite talk about screening. Every talk I do, I talk about screening and vaccines. And the last part, I would not take much time. Some interesting cases which I do apart from gynec cancer. Yes, gynec cancers and breast cancer are big chunk in a surgical oncologist forum, because फीमेल में ये 4 कैंसर ही मोस्ट कॉमन है. मेल्स में ओरल कैंसर, GI cancers are common, lung cancers are common. So some cases which I do apart from this is a breast lump. You might think there is nothing looking like cancer. So what a surgical oncologist does apart from a general surgeon which does a breast lump excision is, we take wide margins initially already when we have a suspicion for cancer. So there is something called BIRAT scores on sonography. There is something on FNAC. We have FNAC criteria also, Bethesda criteria. When we have a doubt, every patient we cannot do a biopsy. When we have a doubt on these tests, we think that this could be cancer, we go wide. So this is a 1 or 2 centimeter margin around the lump which we have taken to prevent the patient to undergo a second surgery. If we only remove the small lump without taking good margins and it is positive for cancer, we again have to go in and take wide margins. To prevent that, we already take wide excision, so this looks like a normal breast lump. In fact, inside there is a hard lump which is palpable. This is some tongue cancer specimens. Just to specify why this image is there, to show you that the lesion is in the center and the margins we take is like 1 to 1.5 centimeter. That is why detecting cancers early is not only important in gynec cancer. Every cancer we must know that early detection is the key. Only when this is so small, we remove that big lump, and still patient has problem with swallowing, eating. So please detect your maybe your friends, some patients who refer to us because we are doctors. काय करू, ह्याच्यासाठी कोणाकडे जाऊ, काय करायचंय? We must know that early detection should be there in every cancer. Now I was talking about that case, the female, young female. This big is the lump which was removed from that female, the left side. Now tell me, how can we detect? Unfortunately, in my relations or in my friend circles also, elderly people are there who have been detected with this ovarian cancer. This is one of the most unfortunate cancers one can have, because detection is very difficult. Breast cancer is on the surface, you can palpate it. Cervix cancer, bleeding will tell you, or some pain is going to tell you. Ovarian cancer is one cancer where you cannot detect it early. Only when it becomes large, it goes and compresses on your intestines or your stomach, and you have feeling of nausea or vomiting. And then you think you have acidity. Still you take some pantoprazole or omeprazole. And after 1 month or 2 months, when it does not decrease, you consult some clinician, and then you know that on sonography there is some ovarian mass. Unfortunately, at that time it has grown to stage 3 or stage 4. So this is one cancer one should not have. This is some sarcoma. This was not for gynec people. Just to reiterate that biopsy should be taken from the location which is closest. In ovarian cancer also, usually, now coming to biopsy, I remembered one more point. Let me tell you. For endometrial cancer or cervix cancer, you take biopsies from pervaginally. For ovarian cancer, is biopsy required? No, not for every ovarian cancer. For those cancers you think that surgery is possible. What do you mean by possible is if there is not multiple peritoneal nodules and the surgeon thinks that he can excise everything that is more than 0.25 centimeter. 0.25 centimeter peksha jasti everything what is seen can be removed by that surgeon, go for surgery directly. If you think that the surgeon is not confident or he thinks that the disease is very extensive, we would want chemotherapy first. Only in that case you put in a needle for ovarian cancer because it increases the risk of staging. The patient who is in stage 1A, you put a needle, it goes to stage 3 if there is a peritoneal spillage. So avoid biopsies for ovarian cancers. Go directly for surgery if you are suspicious. This is some cases. This is a parotid tumor. That is a beautiful parotid facial nerve that you can see all the 5 branches preserved. This is a case of GI tumor. The intestines are all stuck up. Multiple loops gone through the tumor. Unfortunately, a large chunk of intestine had to be removed. These are a few cases which I thought would be interesting to share. This is my profile. This is my OPD. I practice at Viman Nagar in Pune, and I cater patients in Kharadi, Hadapsar, Central Pune, and I'm expanding towards West Pune and PCMC also. I was associated with Sahyadri alone previously. Now recently, just when this talk was planned, I was a full-timer at Sahyadri. Now I'm empaneled to multiple major hospitals and I have a OPD at Viman Nagar. I do not see patients as OPD somewhere else or any specific hospital. This is my OPD, this is my timing, and that is my personal phone number. Thank you so much for your time, and I wish you a good lunch.
Thank you so much, sir. Now, I would like to request our chairperson, respected Dr. Girija ma'am and Dr. Sujit Shinde sir, to felicitate our speaker, Dr. Bhushan sir, with memento and certificate as a token of love and appreciation.
There is an announcement. We are not going to have a lunch break. We are going to continue with the sessions. So please be seated.
Thank you, sir. Thank you, ma'am. Now, I request Dr. Darvi sir to felicitate our chairpersons with certificate and momentum as a token of love and appreciation.
Now I request Shinde sir to please felicitate the coordinator of this session, Dr. Seema Bhaviskar ma'am.
I'm a surgeon, followed by IDJ and station surgery.
We conclude this session. For the next session, I would like to call upon stage Dr. Prachi Bari, and Dr. Vidya Kharat. Sorry for the inconvenience. A small glitch. Tushar sir is stuck in some traffic. We will take the next session.